Hello and welcome to the NJAAP webinar, Understanding Adverse Childhood Experiences, Perspectives on Hope and Resilience. We welcome you to the webinar today. All attendees are muted, and please use the question and answer function to submit questions. We will have a short period at the end of the presentation to take questions. This activity has been planned and implemented in accordance with the accreditation requirements of the Medical Society of New Jersey through the joint providership of Atlantic Health System and New Jersey Chapter AAP. Atlantic Health System designates this live educational activity for 1 credit. A link to the evaluation will be sent via email, and you will obtain your certificate within 30 days. Also, immediately following the presentation, there will be a link to a survey. We encourage all to take our brief survey about your experiences with ACEs in your practice. And at this time, I'd like to introduce our speaker this afternoon, Dr. Shana Groisberg. Dr. Groisberg obtained her medical degree from Tufts University in Boston. Her residency was in pediatrics at Yale New Haven Hospital in Connecticut. She completed a subspecialty fellowship in child abuse pediatrics at Children's Memorial Hermann Hospital in Houston, Texas. Dr. Groisberg was awarded the University of Texas Health Sciences Center Fellowship Research Award for her work with the Abusive Head Trauma Prevention Program, The Period of Purple Crying. She was also awarded first place in the Texas Pediatric Society poster contest regarding her evaluation of residents' ability to manage child abuse patients. She served on the Harris County Fatality Review Board, the Child Protective Services Special Needs Staffing Committee, and the CPS Regional Death Review Committee. Dr. Groisberg is a child abuse pediatrician at the Metro Regional Diagnostic and Treatment Center at Newark Beth Israel Medical Center in Newark, New Jersey. She's an active member of the Helfer Society and has a special interest in child abuse prevention and education. We welcome her to present today. Thank you, Dr. Groisberg.
Thank you. Well, I'm just going to go back to the beginning and say hello to everybody. As she said, my name is Shana Groisberg. I'm a child abuse pediatrician in Newark, New Jersey. And I'm going to talk to you today about understanding adverse childhood experiences, or ACEs, perspectives on hope and resilience. I want to thank everybody for joining us today, especially in the midst of all of the challenges I know we're all currently facing. I have no disclosures to report. So today we're going to talk about gaining knowledge of the ACE scoring systems and the origins of the ACE scoring system, understanding the long-term impacts of ACEs on children, discuss screening for ACEs and some of the challenges associated with screening for ACEs, determine resilience via a questionnaire and discuss that in relation to ACEs, discuss interventions to address ACEs in children and families, and finally, in light of the current situation, to discuss a little bit at the end about ACEs during the pandemic. To quote Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. What makes adverse childhood experiences a public health crisis? Well, ACEs dramatically increase the risk for 7 out of 10 of the leading causes of death in the United States. And currently, there's no standardized routine screening or standardized treatment when ACEs are identified. To take a step back, I want to talk about what ACEs are and how they're linked to our health. The original study on ACEs was this one, called The Relationship of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Death in Adults, the Adverse Childhood Experiences Study. This was done in 1998, jointly by doctors at Kaiser Permanente in California and the Center for Disease Control. The idea for this study began in the 1980s when Dr. Vince Felitti was one of the physicians at Kaiser Permanente's obesity clinic. And he noticed that the dropout rate from his clinic was about 50%. This was really ruining his chances at having a successful program. So he decided to conduct interviews with some of his patients who left the program to find out why they were leaving. So in a later interview, Dr. Felitti explained that he misspoke when he was talking with one of his patients. Instead of asking, "How old were you when you were first sexually active?" he asked, "How much did you weigh when you were first sexually active?" The patient answered, 40 pounds. She burst into tears and said, "It was when I was 4 years old with my father." This really struck Dr. Felitti, and it led to the idea that maybe obesity was a coping mechanism. So he started asking other patients about their experiences with possible sexual abuse as children. He found out that 55% of his obesity patients have been sexually abused as a child. Dr. Felitti later met Dr. Robert Anda, who is a medical epidemiologist from the Center for Disease Control. At the time, Dr. Anda was studying how depression affected coronary heart disease, so he had similar interests. And Dr. Felitti and Dr. Anda set out to understand how childhood events might affect adult health. Initially, they mailed out a survey to over 13,000 Kaiser patients, asking about child abuse and exposure to household dysfunction. They received over 9,000 responses. They did a second wave of the study so that in the end, they had over 17,000 participants in their study. In the survey, they screened for a number of childhood adversities, including any kind of abuse, psychological or physical or sexual, emotional or physical neglect, and a number of household dysfunctions, including domestic violence, living with someone who had mental illness, abused substances, was imprisoned, or someone who had parents who were separated or divorced. Importantly, the questions about exposure to neglect as a child were only included in the second wave of the study. They then assigned 1 point to each patient for each positive ACE that they reported, such that their ACE score ranged from 0 to 10. In the survey that they mailed to their patients, they also screened for some of the leading risk factors contributing to causes of morbidity and mortality in the United States, including smoking, obesity, depressed mood, and alcoholism or drug abuse. They also asked patients about whether or not they had some of the leading causes of morbidity and mortality, including ischemic heart disease, cancer, and stroke. Before we talk about the results of their study, I wanted to show you the 10-question distilled ACEs questionnaire, if you haven't seen it yet, and have you all calculate your own ACE score. I think that it helps put the rest of the talk into some context and perspective. So what I want you to do is, normally I would pass this out, but we're trying a different method this time. I want you to read each question and assign yourself 1 point for every positive answer. Your scores are not going to be shared in any way. This is just for your own knowledge. So I'll start with questions 1 through 3, and I'll give you a few moments to read these over. And again, assign yourself 1 point for every positive answer. Okay, I'm going to move on to questions 4 through 6. Again, I'll give you a few moments to answer these. And finally, questions 7 through 10. Okay. So now I'm going to go over the results of their initial study. And I know from their study that the majority of you probably have at least one ACE. In their original study, 64% of their participants had at least one ACE, and 12.5%, or 1 in 8, had 4 or more ACEs. Which adverse experiences are most common? The results of their study are listed here, but I want to report these results with the knowledge that these neglect percentages were, again, only included in the second wave of the study. So these particular results are not in line with other studies that have been done about the most common forms of child maltreatment, of which neglect is the most common. However, physical abuse in their study was more common than sexual abuse, which is in agreement with other information that we have from other studies. And in terms of household dysfunctions, it was most common to live with a person who had abused substances, followed by having parents who were separated or divorced, and then living with someone with a mental illness. Interestingly, they found that the higher a person's ACE score, the higher their risk for many health outcomes. And I'll talk about a few of those now. The higher a person's ACE score was, the more likely they were to experience alcoholism as an adult, and the more likely they were to smoke cigarettes. A person with an ACE score of 4 or more was 3 times as likely to suffer from depression compared to a person with an ACE score of 0, and 12 times as likely to attempt suicide. A higher number of ACEs meant that people in their study were more likely to perpetrate domestic violence later in life and more likely to have been raped. ACE scores also showed a correlation with a number of diseases as adults, including liver disease, like hepatitis, and COPD. A person with an ACE score of 4 or more had 2.5 times the relative risk of developing COPD as that of somebody with an ACE score of 0. With an ACE score of 7 or more, an individual in their study had triple the risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States. A person with 6 or more ACEs died nearly 20 years earlier on average than those without ACEs. So what is the link between ACEs and our health? Some people looked at this study and said, well, this isn't really science, this is common sense. You have a rough childhood, you adopt bad behaviors like substance abuse, and that leads to these poor health outcomes. But it turned out that even if people didn't engage in high-risk behaviors, they were still more likely to have poor health outcomes. This had to do with the body's stress response and how toxic stress affects the developing brain. When I talk about toxic stress at this point and later in the talk, I don't mean mild or even moderate stress. Mild stress in a child might be something they experience on the first day of school or when getting immunizations. This response is normal and even positive. It can protect us from dangerous situations and let us distinguish between danger and what's safe. Central to the notion of positive stress is the availability of a caring and responsive adult who helps the child cope with the stressor. Even moderate stress, including death of a family member or a natural disaster, can be buffered by a supportive adult. Toxic stress is a strong, prolonged, frequent activation of the stress response in the absence of a buffering, supportive adult relationship. What happens in our bodies when we become stressed? One of the things that happens is that our hypothalamic pituitary adrenal axis is activated, which ultimately releases stress hormones, including cortisol and adrenaline. Again, usually this is a normal adaptive response. For example, if you were walking in the woods and encountered a bear, your body would activate its stress response system, releasing cortisol and adrenaline, which would put you into fight or flight mode to help you deal with the encounter with the bear. To quote Dr. Nadine Burke-Harris, who does a lot of work with ACEs in California, she said, "The problem is when the bear comes home every night and your body is activating this stress response over and over again and bathing your brain and body in these stress hormones." Toxic stress has been shown to affect different areas of the brain, including the nucleus accumbens, or the pleasure and reward center, which has been implicated in substance dependence, the prefrontal cortex, which is necessary for impulse control and executive function, and the amygdala, or the fear response center, which is also an activator of the stress response system. Specifically, studies have shown hypertrophy of the amygdala and loss of neurons in the prefrontal cortex. So people who have experienced toxic stress may have hyperactivation of their stress response and less top-down regulation from their prefrontal cortex. So there may be neurologic reasons for somebody to engage in high-risk behaviors. Toxic stress has also been shown to lead to functional differences in learning and memory, and makes it more difficult for individuals to distinguish between conditions where there may be danger. There's been a lot of work in relating toxic stress and epigenetics, which is an emerging field, and is the study of how the environment influences the expression of our genes. Our DNA accumulates methyl groups, acetyl groups, and other chemical modifications over time that determine how much of or little of and when our genes are expressed. Experiences that children have can change their epigenome. In one study, children who experienced maltreatment had changes across their entire epigenome, including on genes that control the stress response. To understand how ACEs affect our health, this pyramid has been developed, with adverse childhood experiences at the bottom, followed by disrupted neurodevelopment, which leads to social, emotional, and cognitive impairment, and then the adoption of health risk behaviors, which lead to disease, disability, and social problems, and for some, early death. So why hasn't more been done? I said that this original study on ACEs was completed in 1998, and here we are in 2020. If you look at the demographics of their initial study, they're listed here on this slide. You can see that 75% of their population was Caucasian, almost half were older than age 60, and about 75% completed some college education. This was not a study in a high-risk community with minority population with low socioeconomic status. This was truly a cross-section of middle-class American adults. So the scope and the scale of the problem seems so large that it's overwhelming to think about how we might address it. And certainly there's no one quick fix to make this better. It's a complex problem that demands a complex solution. So what can we all do? In 2012, the American Academy of Pediatrics released a policy statement regarding early childhood adversity, toxic stress, and the role of the pediatrician. And they came up with 5 points that pediatricians and other pediatric healthcare providers can do to try to address early childhood adversity. The first is to just recognize that psychosocial problems are not different from biologic health impairments. They both can affect children's immediate and long-term health. The second is to train all physicians about the link between toxic stress and the developing brains and bodies of children, which we're all participating in now. The third is to teach others outside of medicine about the effects of toxic stress, including those who interact with children on a regular basis, including teachers and child protection workers. And I would importantly include parents in that recommendation. If you teach parents that the adversities their children are experiencing may lead to these poor health outcomes, they're more likely to adopt some of the recommended treatments. Another point from the AAP was to be an advocate for the development of new interventions to reduce toxic stress, and to screen for precipitants of toxic stress that are common in your area. Important in screening precipitants is that you want to identify or advocate for local resources that can address those risks once you identify them. I want to focus a little bit more on screening for ACEs now, because I don't have a great screening tool for ACEs to hand you to get you off and running, making sure you screen all your patients. There are a lot of people working on appropriate screeners for ACEs, and I want to talk about one of them now. This is the Healthy Steps program that's being studied at Montefiore Medical Group in New York City. In this program, they start by explaining to families that the more stress you experience as a kid, the more likely you are to have long-term health problems as an adult. Then they say, we have the opportunity to identify these risks and help prevent the risk for health outcomes in your child. Again, educating parents about these realities is an important part of prevention. If parents know the dangers that these adversities present to their children, they'll be more likely to adopt some of the recommended interventions. So they hand patients in their program this survey that's on the screen now, and this is something that the parents will answer for their children. And there are several circles at the bottom of the questionnaire, and they instruct parents to fill in a circle or put a check mark in a circle every time there's a positive response, so that they don't know which questions the families answered positively to, just how many. And they feel that this makes it less intimidating, and parents are more likely to be honest about their answers if they don't have to disclose which questions they answered yes to. A patient with a score of 4 or more would prompt a referral to their Healthy Steps program, which includes infant and toddler care information, a home visiting program, parent groups, and mental health treatment. The reason that there's no standardized and screening tool as of yet is that screening tools need to go through an extensive review process to make sure that they're appropriate for what we're trying to look for. These are screening criteria proposed by the World Health Organization of what makes a good screening program. And if you look at a lot of these, the ACEs screening tools don't necessarily fit the bill quite yet. For example, just this one, we need scientific evidence that our screening program is effective at both identifying kids who have ACEs, and then we also need to be able to refer them to appropriate treatment. Other considerations when screening for ACEs are that there are no reference standards or cutoffs for clinical decision making. There may be other relevant ACEs for an individual or community. For example, the ACEs questionnaire that you all took does not include questions about gang violence. That might be relevant for a certain individual or community, and it may lead to the same health outcomes. The ACE score alone does not account for the timing, frequency, or intensity of a person's exposure to ACEs. A person with an ACE score of 1 might have experienced chronic, intense, unrelenting exposure to that adversity, while a person with an ACE score of 3 or more might have experienced a more mild, one-time exposure to that adversity. This is from a paper by Robert Anda, who you'll remember was one of the authors of the original ACEs study. And his comment was that the ACE score is neither a diagnostic tool, nor is it predictive at the individual level. So if you had a high ACE score on the questionnaire, don't panic. It doesn't mean that you're doomed or that you're going to have poor health outcomes. So how do we know who has poor health outcomes and who doesn't? And we'll talk about that again in a little bit. One thing we can all agree on is tackling this problem requires a multidisciplinary approach. Dr. David Williamson from the Center for Disease Control said about ACEs, it's not just a social worker's problem, it's not just a psychologist's problem, or a pediatrician's problem, or a juvenile court judge's problem. This is everybody's problem. I want to pose this question now. If research based on an upper middle class, predominantly white professional community yields a common finding of high at-risk ACE scores, then what does research on lower income urban communities of minority groups yield? You might think that it just yields doom, but I'm going to show you hopefully that that's not necessarily the case, which leads us to talk about resilience. I'm going to have you do one more questionnaire, this one about resilience. So again, I'll show you the questions, and this time assign yourself 1 point for every answer that you score, that you respond with definitely true or probably true. So I'll give you a few moments to answer 1 through 5 in the resilience questionnaire. And again, give yourself 1 point if your answer is definitely true or probably true. Okay. These are questions 6 through 10 of the resilience questionnaire. Resilience questionnaire is slightly longer. These are the last few questions, 11 through 14. Okay. So how many of these protective factors did you have as a child? And of them, how many are still true for you? What if you had measured your resilience before you measured your ACEs? Would that have changed your perspective on your ACE score? What if you eliminate ACEs that no longer matter or have an impact on your life? Does that change how you feel about your own ACE score? What if you can identify 1 or more protective relationships that are so important to buffer children against these adversities that would buffer you against some toxic stressors? What if you've learned to self-soothe and cope on your own as an adult? Does that change how you feel about your ACE score? I think all of these are relevant questions when we're trying to figure out what somebody's individual ACE score really means for them. All of us live in this increasingly large organization. It begins with the individual in the center and expands to the microsystem, which includes the family, school, and health services included in there, followed by an exosystem, including neighbors, social welfare workers, and legal services, and finally, the attitudes and ideologies of the culture. And each of these systems gives an opportunity to provide somebody with resilience. So I'll go through resilience at some of these levels now. We'll start with individual resilience. This is the ability of a person to withstand, adapt to, and recover from stress and adversity by using effective coping skills. One analogy that's been used by people who study ACEs is that of an orchid and a dandelion. Some people are a little more like orchids. They require certain care and nutrients in order to thrive. But when provided that, they thrive really well, probably better than anybody else. But some people are more like dandelions. No matter what environment you put them in, they're going to thrive. There are some ways that you can help an individual build their own resilience. This can be done through therapy, for example, teaching somebody how to accept and manage change, how to keep things in perspective, to nurture their self-esteem, and maintain hope and positivity, for example. And the next level of social organization includes families. And people's parents or caregivers are so integral in what makes a person resilient. So to save a child, you really need to think about changing the lives of the adults that care for them. This includes reducing parents' adversity, using parental strengths, and educating parents about nutrition, exercise, and sleep, in addition to providing mental health services and substance use services and domestic violence services, etc. At the next level, we have people's communities. And so in addition to assisting somebody with individual or family resilience, we can help people build resilience by recognizing that there are opportunities in their own community. This includes positive interactions with other responsive parents or adults, rich, stimulating community activities. I work in Newark, New Jersey, so here are just some that I've identified in Newark, including the Newark Museum, the NJ Backpack Performing Arts programs. We have parks, the Newark Library, and summer camps. Community resilience includes organized community sports teams, churches and other faith-based organizational programs, and other neighborhood groups. All of these things provide a child with the opportunity to feel that they belong to something and potentially to develop positive relationships with supportive adults. There are broader community programs right here in New Jersey, and I'm not going to go through the details of each one, but I'll talk about some of them briefly. The 2018 Family First Prevention Services Act was an attempt to keep more children out of foster care by providing federal funding for things like mental health treatment and substance use treatment. New Jersey has family success centers located in different areas across the state, which are run by the Department of Children and Families and include services like housing services and life skills training. There are home visitation programs. I think if you really just starting out to find what's in your area, you can start with Prevent Child Abuse New Jersey. They're using evidence-based programs to try to prevent child abuse and child adversities, and they have programs located throughout the state. And I think it's important for all of us to identify some of these community resilience factors and community programs so that when ACEs are identified in your patients, you know you have somewhere to turn to send them. So it's never too late to have a happy childhood. even if a child has experienced significant adversities, if they have a lot of individual, family, and community resilience, they may turn out just fine. I'm going to spend the last few minutes talking about ACEs during the pandemic. There have been a lot of headlines out there, including this one, that the coronavirus could cause a child abuse epidemic. I think this is something we're all worried about. Anecdotally, it's not something we've been seeing here, at least in Essex County, which is the area that my colleague and I cover. Child protection calls have actually been down. And a reason for that is likely because the people that are usually reporting child abuse concerns are not seeing the children right now, including teachers and coaches and therapists, for example. One hospital in Texas has actually already seen a rise in child abuse cases during the COVID-19 outbreak. In some areas of New York, domestic violence calls have spiked, and I know this is true in other areas of the country as well. And we know that domestic violence is a childhood adversity. Some areas of the country have also seen an increase in suicide-related calls. And of course, living with somebody who has a mental illness is also a childhood adversity. Why is this happening? I think some of it is pretty intuitive. Families are sheltering in close quarters and anxieties are high. And we know that the trigger for some kinds of abuse, particularly physical abuse, is simply frustration. And people are anxious about health, about their education, and about finances. And again, like mentioned before, those who normally report abuse cases are not seeing children. So I think all of us who might be doing telehealth visits or some limited visits with children are in a unique position to be able to recognize abuse if it's happening and be able to report it. So I want to finish with 10 ways to avoid ACEs during the pandemic. This is taken directly from acesconnection.com, and this is part of an ACEs in Pediatrics blog that was written by Dr. Robert Siege, who's a child abuse pediatrician in Boston. And some of it is edited for brevity here, but I encourage you to go to the website if you want to look at it in full. These recommendations were really made for the general population, but I think a lot of them can apply to you in your own personal life, or you could advise your patients in these ways, or you could use them professionally in other ways too. The first recommendation is to think about social connection and physical distance rather than social distance. It's so important to continue to nurture close relationships with friends and relatives. Thanks to technology, we all can do that fairly easily. It's important to talk with the children about what's happening. Like parents, children might be fearful or simply missing their routines. There are a number of websites out there who have great principles for talking with children about coronavirus and what's happening, including the Center for Disease Control has some great thoughts on that, the American Academy of Pediatrics, and Prevent Child Abuse America. One way to help guide a conversation with children about what's happening is to ask them what are their concerns and use that to guide the rest of the conversation. Want to make sure that you're reassuring children that although this is serious, they're going to be okay. It's important to reach out for support and encourage your patients to reach out for support, particularly if they have an infant at home. This is because the first 6 months of life are the most dangerous age for child abuse. So being stuck at home with all of these anxieties increases that risk even more. Also important to remind people to reach out to support. Reach out to your friends or relatives who are also at home, particularly ones with infants, again, because infant age is the most dangerous for child abuse related to frustration. You don't have to have all the answers. You don't have to know what to do all the time. Just offering a sympathetic ear can really be helpful. Another thought is to address concrete family needs. This website recommended concretely addressing these needs by getting diapers or cooking a meal or dropping off food. And this might be okay for people that you know personally. For your patients, if you can contribute to local relief efforts or direct your patients who might have family needs to some resources in your area. Address parental mental health. I think we're all familiar with common signs of depression. We should be especially on alert for that when we are interacting with people in our personal lives and patients as well. And if we're concerned, we should encourage them to reach out for help. I wanted to also say there are therapists and counselors who are doing telehealth visits still, so there are still ways to get help. Check in with the children in your life. Again, school teachers and early childhood educators who often recognize abuse are not seeing children right now while schools are closed. So we have the unique opportunity, if we're still doing telehealth or in-person visits, to be able to check in with the children. Talk with the children and not just the parents. Ask them how they're feeling. Be on the lookout for family violence. As mentioned, calls related to domestic violence are up in many places. And there's a national domestic violence hotline that's available to give advice. Finally, engage with your community in whatever ways are possible. Helping others gives everybody a sense of purpose, and that can help counter stress. Create positive moments. Go for walks, play games, bake something together. Look for moments that are going to create happy memories even now. I'm going to finish with that. There are references if people need them, and I'm happy to take any questions via the Q&A tab at the bottom.
Thank you, Dr. Groisberg, and especially for that beacon of hope after the ACEs. We all do have a part to play in building resilience for children. And many of you are asking about the recording and the slides, and yes, those will be made available. So we will take a few minutes now to take your questions. Please type them in the Q&A. There is a question about, is there a Spanish version of the ACEs and where can it be found?
I'm not aware of a Spanish version of the ACEs. I would say that you would just have to use anybody in your practice or programs that you typically use to translate things. It may be available, I'm just not aware of it, but not that I know of. And again, you know, there's no standardized screening for ACEs right now. So while you can, nobody's stopping people from giving the ACEs questionnaire out to patients or families. You know, it's really not intended for that purpose at this time. And people are looking for different ways to appropriately screen patients and families. And I think a lot of what pediatricians particularly do already screens for some of these things. For example, if you are asking parents what they're doing for discipline and they mention using corporal punishment, that can be a red flag for possible physical abuse. You know, if you're asking parents if they feel safe at home, if a mom brings her infant in, and that's screening for domestic violence, as some examples.
Can you comment about using the ACE questions in pediatric offices?
Yeah, I think we just talked about that, but again, you know, the ACEs questions themselves, you can use them, just you have to know that they're not standardized. Again, they don't identify how intense or frequent an ACE has been for somebody. And also, one thing I forgot to mention during the talk was that the ACEs questionnaire also doesn't determine when this ACE occurred for that child. So we know that ACEs that occur for a child in a critical developmental period, for example, in their early childhood development from infancy through toddlerhood, may have a bigger impact later in life than if they experience that adversity much later. So there are definitely limitations to using the ACE questionnaire directly in your office. And if you do use it, you really have to have resources to be able to send these people to if you do identify ACEs. So you want to make sure first that if they do answer positively, you know what you're going to do about it. And I see that somebody mentioned they don't have enough resources after screening, and that is a huge problem. And I think there's a push for pediatric offices and others to become more linked with some of these community resources for this reason. You know, we encounter children all the time, and we encounter families and have the opportunity to identify these things, but we need to have something to do about it. So for right now, it's just about doing some research, reaching out to maybe your own American Academy of Pediatrics in your state, or looking at Prevent Child Abuse America and seeing if you can find information in your area, or really doing some digging to find out what your community does have to offer.
We are getting quite a few questions about our pediatricians using this. And so if you're a pediatrician and you are screening, if you would respond in the chat, and just use the to all panelists and attendees. There is some information being entered in the chat for all to view. There's another question about ACEs being culturally founded. Do certain communities of color have access to change their ACEs questions that would not compromise the diagnoses?
If I understand the question right, I think that's getting at the fact that the ACEs doesn't include some questions that might be relevant in different communities. And so we just don't have, you know, it's still in the early stages of, you know, studying, screening for ACEs. The ACEs, the original ACEs research study, again, was simply about finding a correlation between adverse childhood adversities and adult health outcomes. And the purpose of the ACEs questionnaire was not to screen patients. And so there are certainly, you know, communities that may need different ACEs questions or et cetera, that we just, you know, haven't fleshed out yet and that people are researching now.
There is a tool, the PEARLS tool, and are you familiar with that? Do you have any comment about the PEARLS?
Yes, I mean, again, you know, there's a lot of, PEARLS tool is another way to screen for ACEs that's being studied currently. And I think that's really important. And if you have the opportunity to be part of that and be part of, you know, trying it out and helping people learn more about it, I think that's great. And I think we should all, again, try to participate in some of the research that's going on about this if we can, so that we can learn more and have some of these answers that I don't have for you now.
There's a question about the role of the school nurse. What do you think this school nurse's role would be?
I think the school nurse's role can be somewhat similar to the pediatrician's role. I guess it sort of depends on, you know, how you function as a school nurse in your own area and in that capacity. But certainly, you know, even teachers, again, it's important, teachers and school nurses, it's important to educate everybody about ACEs, because they encounter children every day too, and they're likely to identify ACEs, signs of abuse or neglect, or learn about domestic violence in a family. And so I think the role can certainly be in identifying these and then notifying, of course, Child Protective Services when appropriate, and learning, if you can, about resources in your community. And maybe, you know, I guess it's trickier as a school nurse to recommend that to a family, but maybe giving that suggestion to the appropriate authorities that you report it to. Or even if it's an older child, you could recommend that the child reach out to some of these community programs if that's appropriate.
Another question, the National Survey of Children's Health identifies household economic challenges as the most common childhood adversity. How do you think about other adversities than those identified in the original ACE study and their implications for pediatric practice?
Absolutely, and some other adversities are, closely linked to some of the adversities that were listed. We know that, household economic challenges are linked to some of the other things that were listed. And again, thank you for saying, I'm sure there is a Spanish language version of this ACE, I just haven't come across it myself. I think there are several other things that aren't included or weren't identified in the original ACE study that are certainly important for children and certainly impact their long-term health. And I think that's part of the role of the ongoing research that's happening now, is to identify what are those, and then what should we use a different screening questionnaire in different communities is a great question. I think potentially yes. Should we use different screening questionnaires for different cultural backgrounds? Maybe. Are there other adversities that weren't identified that are potentially also important? Definitely. So I think that's the role of this ongoing research. Certainly those 10 ACEs in the questionnaire are not the only things that affect children.
Can the damage done in children with high ACEs be reversed in adulthood?
Yes, so actually children's brains have plasticity, and so some of these epigenetic changes and some of the changes in the brain can actually have been shown they can be reversed in adulthood. So that's good news, and a lot of it has to do with buffering, again, by a supportive adult relationship and building those factors of resilience. So it's not a life sentence necessarily.
Great. And then let's see, we have time for a few more. There's a question about schools. A comment, I have recently done a couple of webinars on ACEs. It has been around for a while now. I find it so interesting, relevant. I feel that our school systems are not really adapting to how we educate and treat students with a lot of childhood trauma. Do you see for the future schools changing how we educate these students and treat them?
I hope so. I think there's a big push for there to be a change in both, the medical care, medical model of how we're treating children, to really shift to sort of looking at more at these psychosocial issues. And I think the same should be done in schools. And I don't know how that's going to look or the best way to do it, but I think that we should be educating the children themselves as they get older about some of this too. Although the best way to prevent some of these is early intervention. So identifying it at the earliest point you can and intervening then is going to help do the most to prevent future issues for that child.
And I will say that New Jersey AAP does have some programs that we are linking with principals and school nurses and superintendents to partner together to really look at this issue and make some changes regarding the way children are informed and linkages between the pediatric health team and the educators.
And
some beginning work on that, yes.
And thank you to Maria McColgan, hello, who mentioned that a great way to do something in your community is to volunteer to give a talk at schools to teachers, staff, parents, and students themselves about some of these issues.
And a comment, please reach out to local school counselors. And thank you for all your positive comments. And again, the slides will be available as well as the recording of the webinar. So thank you all very much. If you are seeking CME credit, please remember to complete the evaluation. The link will be in SurveyMonkey, and you will receive your certificate within 30 days. And we also have a very, very brief survey on your experiences with ACEs in your practice. So we'd appreciate that if you'd complete that very brief survey. And thank you very much, and have a great afternoon.
Thank you.